good afternoon, and thanks for joining us for a brand new Healthline 3. I'm Nate Fluharty, and over the course of the next half an hour, we're going to be focusing on ways that we all can live a healthier, happier, and pain-free life. We're going to be taking your calls and most importantly answering your questions and opening up the phone lines in just about 5 minutes from now. So when we do that, once we get into today's topic and start taking your calls, you want to find yourself somewhere we can hear you. So get to a quiet part of your room, turn down your TV, and give us a call. That number to call is 318-219-4569. And with all this being said, we got a great topic for you today. Let's dive right in, and we're doing that with today's featured guest, Dr. Kyle Pritchard from Willis-Knighton Orthopedics and Sports Medicine, Piermont. Dr. Planchard, great to see you, sir.
Thank you for having me. It's a privilege to be here. Looking forward to talking about weekend warrior injuries.
Yes, this is a good one too because, you know, you and I were just kind of talking on our KTBS News Midday, a little snippet here. This is a topic too. Whether you're 20 or 92 and everywhere in between, this is a topic because we all get injured and we all feel those aches and pains. This is a good one today.
Appreciate you being interested in the subject. I think that yes, even at fresh out of high school, you're in college. Maybe you're an athlete. You can still be an athlete, but your structure has changed. You're going to class a lot. You don't have the consistency of coaches on you telling you that you need to work out, but you still show up to the gym and you're playing recreational basketball and things like that. In your 20s and your 30s, life's a little different.
Yeah.
You can be a weekend warrior, and then certainly in your 40s and your 50s, you're staying active, and maybe you have more responsibilities, kids and a job and anything else in life. So, and then hopefully stretching it out to any age. We love to tell people everyone's an athlete. I'm a orthopedic sports medicine surgeon, and so you have that title sports next to your name, and people might think that they don't need to come see you because they're not an official athlete. But this definitely covers that spectrum where there's definitely injuries in this spectrum where even someone who is highly regimented, official athlete, if you will, can have all these same injuries. So this definitely speaks to anyone and everyone.
It sure does too. So who should call? Well, if you're watching right now, you have that pain in your back, or you used to be a pitcher 4 or 5, 40 years ago, and you're dealing with some pain, some stiffness, soreness right now. What can you do about it? We'll pick up the phone here in just a little bit and give us a call. Dr. Planchard is here to get you some answers on that. So, Dr. Planchard, if you would, let's kick things off this morning, kind of talking about what you do at Willis-Knighton Orthopedics and Sports Medicine there and over at Piermont location, and kind of how you help people out and especially some of your patients.
Absolutely. I appreciate you asking that. I'd say my doors are open to talk to anyone like you offered to call in here. If you're hurting, you're welcome to come in and talk to me. My specialty is a focus in orthopedic sports surgery, which tends to revolve around a variety of joints. That's shoulder pain, elbow pain, hip pain, knee pain, ankle pain. And so I just kind of said every major joint in the body. So we can get you started, figure out what your problem is and what your problem isn't, try to give you some information and some first steps. Obviously, as a surgeon, sometimes those things lead to areas that I have special training in. If none of the simple stuff is working out, we can get to some surgical answers for these body parts, but I'll also I'll try to start you out on easy non-operative treatment plans and get answers. And so my focus, I would say, is more arthroscopic management of shoulder injuries, rotator cuff tears, elbow injuries, pitching injuries. If something goes pop in your knee, that kind of falls under the line of what I'm probably going to be doing. And so a lot of, there's open surgical treatment. There's definitely a treatment of fractures, kind of general orthopedics that I do as well. But the subspecialty is more around arthroscopic management of any of those joints.
Would you say the goal is always to try to, is surgery always the last, kind of the last thing here? I know for certain other, medicals, they try to wait, doctors, but I know with some things you tackle, sometimes surgery might be the best option, right?
That's a good point. And I think that depending on what patient meets me in what context, they might feel like I'm really slow to do surgery. They wanted surgery a year ago and they felt like they thought that that's what they needed potentially. And I'm recognizing that no, a lot of people are going to get through this problem with time, and we don't want to operate unnecessarily. And then sometimes people come through the door, you look at the x-ray, you look at the MRI, you hear the story, and you say, hey, this is something that actually will be worse in 3 months. It'll be worse in 6 months. There's not a good outcome outcome on the other side of non-operative management. And some of that's judgment, some of that's complicated. And I'll recommend surgery the first time I meet you, potentially, depending on what it is. Now, even in that worst case scenario, in orthopedic surgery and orthopedic sports medicine, I mean, this is never a heart attack. This is always a musculoskeletal injury, pain, loss of function. These things really matter, and we want to get them right. And but I'll always tell you, you don't have to do surgery as long as you understand, maybe where we might be in 5 months.
Kind of like a quality of life thing.
Correct.
And that's one thing too, I'm sure that you hear. I know a lot of medical professionals do that line, I should have did this a lot sooner. Yeah, we're going to be just about open the phone lines here in just a second. But Dr. Planchard, I'd like to tackle first what are some of the main problems that you see? Who are some of the typical patients that you're helping out?
Yeah, that's a good question. I think mostly it's people coming in who, let's say in the shoulder, it's probably one of two people. One is it just started aching. They come in, they just say my shoulder just hurts. It hurts to sleep on at night. I'm having a hard time reaching in the back seat to do something or reach behind my back. And that person, just a common person is this chronic rotator cuff pathology. It's a very common problem. And so I think you probably know a lot of people, have heard a lot of people who have rotator cuff this or rotator cuff that. Sure. I think that there's a big spectrum on that injury list of the rotator cuff's a big topic as far as you could have some irritation, some tendinitis, some bursitis, where the tendon itself, the rotator cuff tendons are perfectly healthy, or they're not torn per se, but they're irritated, they're having a hard time, and there's certain treatment options for that. Versus another story is someone comes in and they were trying to lift something in their yard or something and they felt a pop and now they can't lift their arm over their head. Same structures, but it's this acute injury, and those are the ones that we're probably more likely to have to do surgery for.
Wow, pretty interesting. It can happen just in the blink of an eye like that. How simple that can be. Well, with that being said, let's do it. Let's open the phone lines right now. 318-219-4569 if you have a question for Dr. Planchard here. If you're feeling the aches and the pains, maybe you have a nagging injury that's just been around for too long. Maybe it's an old sports injury. Pick up the phone, give us a call right now. We'll try to get some answers as far as how you can get some relief from that. Now, you touched on something a second ago, tendinitis. Is that, first off too, is some of these injuries like that, are all of these sports injuries, can Susan out there watching, can she develop something like a tennis elbow or tendinitis and maybe never played a day of tennis in her life?
That's a great question as well, because tennis elbow, it's probably 4% of people with it actually play tennis.
4%?
Yeah. And
why do you call it?
In prep for this talk, I looked that up.
Right.
And don't worry, Susan, you're going to be fine.
Good.
But so tennis elbow is an interesting one. It's most commonly laborers. What it really is it's lateral epicondylitis, if you want to get fancy. What that refers to is just the lateral epicondyle. If you press around on your elbow and you feel a knob out to the outside of the elbow, that's your lateral epicondyle. And a lot of muscles in your forearm come in and attach to that piece of bone right there. And those muscles are called your extensor tendons of the forearm. It's a group of them, but the one that can kind of degenerate over time, and this is something that it's interesting. We call a lot of things tendinitis. We have a quick, not trying to get picky on this, but tendinosis is another word, and that's where these tendons can actually just become unhealthy. Tendinitis is where they're inflamed. Maybe you just overdid it one weekend, just kind of a generalized overuse in a moment, and it's actually inflamed and the tendon's unhappy, and that's the kind of thing that can kind of calm down, take some anti-inflammatory meds. But tendinosis is something that can happen in tendons where just over the course of a lifetime, and to answer your question, not necessarily an athlete, but a typer. A person who's constantly doing that wrist extension move where they're flexing these extensor muscles, or someone who just grips things a lot. That grip movement really forces those muscles to contract. Yeah. And so that repetitive, long-term, just using it more than it can recover from can lead to the tendinosis side of things is just a change in the quality and health of the tendon as it inserts on that bone, so that whenever you do those activities again, it irritates it.
So that's kind of like, and I find that fascinating because somebody watching right now is probably thinking, I have had that problem for years. Who would ever know that it would be something like a tennis elbow, right? Somebody that's never even picked up a racket. Sure. So that's pretty fascinating. And I'm sure that goes along the lines too of another common problem, at least we here in the office space, is carpal tunnel.
Oh, sure.
Yeah, can you break down that is, and do you again kind of same lines? Is it a repetitive work thing? The reason people are typing and just don't get a break for their body?
Yeah, no. So carpal tunnel certainly can come out with repetitive activities for sure, but it also doesn't necessarily start there or have to start there.
Okay.
And so carpal tunnel is just the median nerve, one of the major nerves that comes out of, you have your spine, and then you have the brachial plexus, and then eventually these separate into some pretty defined nerves, where some of these nerves, particularly the median nerve at the wrist, goes through a tighter space than at other parts of the arm. And so as it's going under the transverse carpal ligament at the anterior surface of the wrist here, it has bones underneath it. It's got this kind of the floor of it. It's got this fibrous band of tissue on top of it, and it's supposed to go into your hand and supply sensation and do all sorts of good things. But whenever that ligament and the general space in there that ligament can get thicker, the nerve can get compressed, that can just happen with time. But also certain positions decrease the space for it. And so it has more space in a neutral position, it has less space in a flex position. And so jobs that kind of involve prolonged flexion, jobs that do use your wrist more, it's not so much that those things are high risk for causing carpal tunnel, but if you have any precursor to carpal tunnel, you kind of have it brewing, but you wouldn't know about it if you had a different job maybe. Those are the people who might experience it more often.
All right, interesting too. Let's branch out too for some of the former athletes that you're saying. Is it? I would imagine you're seeing back problems, knee problems, things like that. How do you even go about treating something when it comes to the body and getting older? I'm sure there's parts of our bodies that just don't regenerate like they used to.
Yeah, that's a good point. I think that there definitely are moments, even in younger people. I think it's the same conversation. If you have a 15-year-old who comes in and they're hurting somewhere, maybe they have an acute injury, maybe there's a specific reason for it, and we're going to get to the bottom of that. But sometimes at the other side of a conversation, you're like, you're training 4 hours a day. You're 12 years old. It's like there's only so much that your body can handle at that age.
Sure.
And then, in the prime of life, at your peak, if you're LeBron James at 26 years old, almost no flaws, you can handle a lot, but you still have a threshold. And then there needs to be, like LeBron James at this point in his life,
Right.
there's things called load management. There's a certain amount of stress that he can take at around 40. And so that definitely applies, where someone can come through the door and maybe I have to helpfully nudge them towards maybe that's not, or that volume of that activity. We have to kind of, as a doctor, we might not have a fancy answer where
Sure.
your body might not be able to sustain that, but as much as possible, we want to try to fix the problem and keep you active, because staying active is going to be healthy for you in the long term.
That's a great point, Dr. Planchard. Actually, one of the things Tom Brady said was the hardest points of his career was acknowledging and scaling back on what otherwise was a championship routine. But if Tom Brady can do it, we can too. All right, let's go to the phone lines. We got our first caller here on Healthline. I believe we have Bernice. Bernice, good afternoon. What's your question for Dr. Planchard? Bernice.
Hello.
There you go. We got you, Bernice. Good afternoon.
Hi. This is Bernice Jackson. I had back surgery in 2010. I had L4 and 5 discs removed, and they put the regular screws in my back. But every once in a while, kind of frequently, it will flare up. It hurts so bad, it'd be excruciating pain. And I have to go to ER, and all they do is give me a shot and tell me to go see my primary doctor. But they think everything will be intact. No screws or bolts or anything loose.
Okay.
It'd be just inflammation and pain.
Got it. Yeah. So just to make sure I got that question. In 2010, you had surgery on your back, and it still flares up on you and it bothers you from time to time. The role of the ER for sure is to evaluate you and make sure that there's not some life-threatening condition or something that needs to happen where we need to bring you into the hospital and save some situation that would be a disaster if we missed it. When they refer you back to your primary care, I'd be curious, are you seeing your original surgeon? That would probably be the person to have that discussion with, because advanced imaging to look at your construct, look at those screws you're referring to, make sure that after 16 years, nothing's loose. It sounds like you said the imaging looks normal, but if those conversations are happening with your primary care, I think that a spine surgeon, either the same one that you had before, if you have access to them, or we have good ones at Willis-Knighton if you want to come in and see someone there.
Okay.
Now, as far as the aches and pains side of things, a little bit more of an answer. It does become trickier when we're not dealing with kind of a new injury, but kind of chronic pain going back to a surgery. Spine surgery is a big deal. When you start to put implants in there, you kind of change oftentimes you make someone better, but it's never quite the same when you have a fused spine, and that is a concept of whatever section has had a lot of hardware put into it. The nearby sections can wear down over time, and I would not claim to be a spine surgeon. That's adjacent to what I do, and you learn a little bit about that in orthopedic surgery, so I don't want to get too deep into it, but I think that's the best next step.
All right, Bernice, we hope got some answered for you there. Thank you, Bernice, for that call. 318-219-4569. The line is wide open there. Make sure you find yourself somewhere quiet so we can hear you right there. And if we're dealing with aches and pains, pick up the phone, give us a call right now and get those questions answered by Dr. Planchard. And Doc, backing things up right there, just kind of springboard up to after what Bernice was asking right there.
Mm-hmm.
Let me not to make it about me, but even I feel back pain sometimes.
Yeah.
I'm sure that at some point people do.
Yeah.
Is that something that we can always anticipate getting worse as we get older? And when do we kind of start bringing it up to our doctor that, geez, it's every morning I'm waking up with back pain?
Yeah, no, back pain is extremely common. It is something that I think every person, hopefully not every person, but a lot of people will experience. I don't think it's hopeless. I don't think that there's no answers. I would say the red flags, the key, hey, I need to go see a doctor on the back pain side of things, is new acute numbness and tingling. Okay. Anytime we're dealing with, because there's a big difference. You got the spine, you have the spinal cord. It's running in a relatively tight space, even at best. It's protected by bones, the vertebrae that are protecting the spinal cord from serious injury, and then it's shooting out nerve roots that go down your legs and into your feet and all that kind of stuff. And whenever the nerves get compressed, well, it causes numbness and pain. It can be pretty miserable. I would say if you're in that boat at all, for any sustained amount of time where you have what's called radicular symptoms, that radiating pain, you might have back pain and also you have something that's shooting down your legs, it's probably worth going in and seeing an orthopedic spine provider to figure out what that is. That's still not an emergency. You can schedule that appointment at your convenience. But if you had new severe numbness and changes in bowel and bladder habits, that's the ER. That's get looked at really quick. As far as taking the nerve side out of it, back pain, maybe it's off center, it's muscles, they're tight. I have recurrent problems with that too, going back to playing high school basketball.
Sure.
One play, I twist and that rotation, it's like my back went out. Like I assume I'm a 40-year-old man. And I could hardly walk for a week. And now over the course of the past 20 years, I can go do something and tweak it, and it kind of
still feel it after all these years.
Yeah. So these little spine, these little back muscles, if they've been stretched or strained and had one of those injuries in the past, they can definitely kind of have a propensity to go back into that spasm and things like that. Core strengthening, all the things that we neglect as far as building up the little muscles in your posterior chain. A lot of times when people go to the gym, they're very front heavy, whether it's the chest and the shoulders or the quads, but building up your muscles just in a more general way. That's why a lot of times we throw the word physical therapy at everything. You go see a doc, they just want you to do physical therapy. Right. It's really a reflection of the fact that unless you're a personal trainer yourself, or you're very deep in the weeds, anyone can do this on their own. But I think the things that you say, like, is there hope, more or less? I think that a really disciplined, stretching, strengthening, well-rounded core and lower extremity strengthening program can have a lot of benefit for back pain, and particularly flexibility in your hamstrings.
That's a big one. Yeah. Flexibility seems like a very big thing too. You look at when we get older, it is tougher to move, a lot more pain thrown in. And it is a very fine line. I noticed with me personally, a very fine line between acknowledging I'm getting older versus, okay, this is something that I should probably bring up with my primary doctor and at least get the ball rolling. Now, I know this is a big issue as I branch out to this. 10 more minutes, so pick up the phone, give us a call, 318-219-4569. And I know we got some viewers out there dealing with this. I want to bring up arthritis. And that, I'm sure for someone that lives long enough, they're going to be dealing with it. But specifically, how does that deal with former athletes and what you're saying for the typical patients? Is that something that if I injure a part of my body, I'm going to get arthritis in that?
Yeah. Actually, that definitely is a defined subcategory of arthritis called post-traumatic arthritis. So that definitely exists. Now, not every injury, but actually, if we go through it, a lot of different injuries can potentially have some increased risk of arthritis. So to back up, even though this is a word that we use a lot, arthritis is the word technically is talking about inflammation of joints, but it's essentially a degenerative process involving a joint. Joints just being where bones come together. At your knee, it's your femur and your tibia. It's, the knee joint. The shoulder, you have the ball and socket, the humeral head and the glenoid rotating together. But those are the major joints. You have your hip and your ankle, but you also have not a million, but small joints in the body where you have bones that come together and they have cartilage on the ends of them, and cartilage is smooth, it glides, you're born with lots of it. Over the course of a lifetime, if that cartilage wears down for any reason, and those reasons can be wear and tear, it can be just lots of life, lots of activity, lots of, there's risk factors for it genetically that you can't control, there's risk factors for it at a weight level where we know that a person's height to weight ratio relates to whether or not some of these joints wear out. And more than that, but there's also post-traumatic arthritis. So if you tear a ligament in your knee, like your ACL, common injury, athletes run around, feels a pop in his knee. We know that people who tear their ACLs are more likely to get arthritis in the future. And that's because that stability that the ACL provides, it has your knee locked down a bit. There's only so much motion that those bones are supposed to have in relation to each other. With a lack of stability, it just wears out faster. If you break through the bone, if you break through that articular surface, one of the reasons at the joints we're so picky about, that's one that needs surgery compared to maybe some other areas we can do casts or other things. A fracture that goes through the joint line that violates that cartilage and that surface, or that makes an irregular kind of, instead of being smooth at a joint, it's stepped off. If we don't fix that, then there is a significant increased risk of that joint kind of deteriorating and becoming arthritic.
And arthritis is something surprisingly people of all ages experience. It's not just a senior citizen type of thing, right?
Yeah, absolutely.
It might not be common though.
Yeah, I think maybe at a young age you'd be shocked. Some 16-year-old, that's not a thing,
really?
right?
Okay,
There's a certain amount of life where it's tough. Now I will say, even 16-year-olds, there's autoimmune and rheumatoid. There's juvenile arthritis. There's inflammatory conditions that unfortunately can destroy joints at young ages. But the typical wear and tear pattern of kind of a lifelong of wearing a joint down, that normal osteoarthritis, you got to be a little older. But like you said, it definitely can happen to anyone. You'd be surprised. You can walk in clinic in your 30s and 40s and say, this joint is in the process of wearing out. Sometimes when we catch that person, it's a good chance to say, hey, we don't want to do a knee replacement on you. You're 35, you're 40. And then you look at what the modifiable risk factors are. You might not be able to affect the fact that you had that ACL injury. You might not be able to affect the fact that your genes might push you towards, maybe everyone in your family's had arthritis.
Right.
But the modifiable things would be, are we want to stay active, but are we doing high impact activities all the time? Is there some way we can transition you from being a marathon runner to a long distance biker? We can be friendlier to our knees. And then also, I've already mentioned weight. That's every step of your life. We all have a few pounds we could drop, and that reduces the stress that our knees and hips see.
I'd like to ask you this too. What is that moment, or is there, when we kind of stop taking it for granted, the normal aches and pains, the weekend warrior injuries, and wow, I should probably see a doctor about this? Break that down for us.
Okay. So if you're out there playing pickleball or something and you feel a pop, well, you feel something happen. It could be something, it could not be anything, but if after that injury, your knee feels or something feels unstable. I would say instability is a bad sign. Not just like it hurts. You're always welcome to come in and see me. But if there's a notable instability to your joint where it feels like the joint itself wants to give out, that's a good sign. If you feel something mechanical, there's something called mechanical symptoms where after an injury, I could probably get some joint to pop, and I'm sure we both can. Yeah. This pops from time to time. If it doesn't hurt, if it's something that's been there for a while, well, we're not too worried about popping. That's okay. But if you just had an injury and now something is popping in a very discrete way, well, on the other side of an X-ray or an MRI, there might be a structure, particularly say like the rotator cuff. There's a time limit on that where if it's a big tear, the tendon itself can get unhealthy over a prolonged period of time, where it's harder to repair in the future versus we could have done it early. If you have significant weakness in the shoulder, if you go from a very functional shoulder to a dramatically weaker, less functional shoulder in the moment, that's a sign of like a rotator cuff injury likely that, like I said, we need to promptly be figuring that out. If something swells up significantly, you should see a doctor. Maybe if you know that you have knee arthritis and you know that your knees will kind of swell when you do a little too much and it's not outside the normal, you're playing tennis and you go a little harder and it swells a little bit more, that's fine. Yeah. If you don't normally have routine swelling and you have one of those discrete injuries and this knee's fine and this knee looks like a watermelon or something, then something happened in that knee and it's probably better to get it sorted out quicker.
Yeah, fantastic. Great answer there, Doc. Appreciate you breaking that down for us. I'd like to kind of springboard too, if we can, to ask you a personal question here. It's baseball season. It's going to be football season. Some of those kind of sports. Is there any advice, especially for throwing? I know in the game of baseball, baseball coach here, that there was some major concern right now in the game of baseball for throwing. How many pitches are too many pitches? Can you shed some light on that, if you would, for maybe some of the coaches out there thinking, hey, it's okay for my kid to throw 200 pitches or 200 innings. We got to win this tournament. Is there any concern, or when does that concern kick in for our kids that we're pushing them too hard, especially their arms?
Absolutely. I think that, that subject that you led with as far as the frequency and the volume is really where we've landed largely on the biggest issues for injury risk. As injury risks have skyrocketed at every level, getting younger and younger, UCL injuries, the ulnar collateral ligament leading to the Tommy John surgery, repair, the frequency of injuries even coming out in the past 4 or 5 years in the majors, but also going to the youth level, younger and younger, almost expecting to have these injuries, has skyrocketed. You're right to say that. I think historically we were a little bit more trying to demonize curveballs and demonize this pitch or that pitch.
Yeah, right. We always heard, wait until they have underarm hair before you throw a curveball. But then you go and all the other kids are throwing curveballs.
Right. And so we're circling back around to the question you asked, 200 pitches. I think we all know that that's a bad idea. But the volume side of things, and I say we all know that, but we'll do it. So yes, too much volume definitely correlates with shoulder injuries, with elbow injuries, with pitching type injuries. The signs that you're overdoing it would be if you're having elbow pain as a pitcher. There's some clear red flags. There's some clear things that I wouldn't tell a junior pitcher to go push through. Pain, worsening pain, right. Stuff that it's recurrent. Certainly, if it's getting the worst direction or it's heading in the worst direction. I don't think that I personally am going to go tell a kid a strict pitch count as though I really know what his arm can handle. Yeah. And I'm also a bad person to ask because when I was in middle school, I had a scaphoid fracture and docs put me in a cast and said my season was over, and I found a way to go out there and play. I understand the feeling in middle school of this is the championship, but I guess the answer would be recognizing, hey, from a long-term perspective, we don't need to be pushing through pain at that age.
Rookie of the Year was just a movie. Okay, for those that remember, Henry Rowan-Gardner. Well, Doc, today has been amazing when it comes to answering some of our questions, when it comes to weekend warrior injuries, some things we all know. For folks that didn't get a chance to ask a question today, can they reach out at Willis Knight Orthopedics and Sports Medicine?
Absolutely. You can come see me. You can come see my partners. I'm happy to see you taking patients. If anything's bothering you, if you had a tweak or a bump or a bruise or something that's been going on for a long time or a short time, I'm happy to see you and get started to figure out what it is.
All right, fantastic. Well, great Healthline today. Don't be a stranger. Hopefully we get you back very soon.
Thank you so much for having me.
All right.
Enjoyed it.
And keeping you guys on the field and the little ones safe. That's going to do it for today's Healthline 3. Remember to keep it tuned for much more and always on ktbs.com. Have a great day.